Great, thanks. So today we're really pleased to have Ashley Mollison with us, who will be talking about recognizing and valuing caregivers to improve life and death experiences of underserved and excluded communities. I actually met Ashley through some work with Healthcare Excellence Canada, but she's also a PhD candidate at the University of Victoria. Then we'll go over some resources. And just a heads up that the next meeting is actually in September, September 23rd, and we'll have Compassionate Alberta sharing with us. So I will stop sharing my screen and
Helen,
hand it
I'm
over
just
to
going to
you.
jump in about
Mhm.
the series starting in September. I will be sending out with the follow-up email that'll include the slides from today as well as the recording link. I'll send out the registration link for the new series.
Great, thank you. Okay. Over to you, Ashley.
Thank you so much, Helen. And I'm really happy to be here with you today. Thanks to Helen for inviting me and also to Kate for organizing the session. So I'm going to chat for a little bit and then hopefully we will definitely have time for discussion at the end. So I'm just going to start with my own territory acknowledgement, just to let everyone know that I'm calling from Treaty 7 territories in the Métis Nation of Alberta District 4. I live in Cochrane, Alberta, just outside of Calgary. And this is a picture from behind my place. And one of the things that I've kind of, through my journey, I guess, of myself, I'm a white settler. I come from Scottish descent. And one of the things that I'm really coming to learn in my journey towards decolonization is my role, which I see as really starting to kind of pick apart or contributing to picking apart some of the bias and the assumptions that we hold in our systems. To make space for different knowledges, for Indigenous approaches, ways of being, from people who have looked after each other in family systems, in extended family systems, and in community settings for time immemorial. So I'm going to start with a few anecdotes to share a little, to kind of ground us in what we're going to be talking about today. And then I'm going to get into the meat of the argument. So Tommy is a homeless man. He calls the hospice unit to inquire about his street brother. When asked about the nature of their relationship, he replies, friend. He's told the information can only be provided to family members or close friends approved by the patient. Tommy decides to visit anyways, instead of lining up for lunch or a mat at the shelter, forgoing his food and a place to sleep that night. When he arrives at the hospice, he's met with questioning looks, and he's told to leave his backpack at the front door as the room is crowded. He feels judged and questions if he should come. He's worried about leaving his worldly belongings at the door, so he decides to leave, and he doesn't return. After a brain aneurysm, David ends up in the ICU. His partner of 20 years, Loretta, who he refers to as his wife, is not called because there's no legal recognition or documentation of their relationship. Hospital staff see that David has an emergency contact on his electronic medical record. They call the number to find out it's his biological sister. Estranged for the last 10 years, David's sister flies in from another region of the country to provide care and make decisions until he dies. Loretta fades into the background, unable to offer care or say goodbye. David's ashes are sent back to his family in another region of the country, while his partner grieves alone on the street. Nancy, a woman with severe lung disease, lives in transitional housing, supported by a case manager named Georgia. Over the last year, Georgia has become very close to Nancy and learned that her family doesn't visit her anymore. One day, the manager of the housing unit comes to Georgia to ask if Nancy's level of care is too high for the facility. Georgia says no, because she doesn't want Nancy to be evicted and sent to hospital. Georgia begins doing more for Nancy on the side, such as taking Nancy's clothes home to launder and cleaning up after Nancy's incontinence. One day, Nancy has a fall, and Georgia is wrought with guilt, thinking that she should have told management earlier about Nancy's decline. Unrecognized as an important part of Nancy's caregiving network, George is left to deal with her complicated feelings as Nancy is sent to the hospital, then long-term care to spend her remaining days. So our work over the last 10 years at the University of Victoria through Dr. Kelly Stajahar's program of research in equity and palliative care really started and was rooted in the experience of workers. So these workers were housing workers, shelter workers, outreach workers, peer workers, Indigenous workers, who were seeing the people that they cared about and supported die alone, without access to pain and symptom management, um, unable to get out of their units, living in places unfit for human habitation where home care wouldn't come and visit. So they did what they could to meet the needs of people off the side of their desk. And they said, we really need funding to be able to serve the end of life needs of people that were homeless, people living in poverty, people who are racialized, using drugs, experiencing mental health issues, and other inequities in care. And when they went to go and ask for funding, the response was, we can't fund you because there's no evidence that people are dying on the street alone and in these circumstances. So we started, we applied for funding, and we started to conduct research to really understand the end of life experiences of people facing homelessness and other inequities. And we ended up producing a study called Too Little Too Late: How We Fail Vulnerable Canadians as They Die and What to Do About It. And ever since then, we've been engaged in work to improve access to healthcare at the end of life in the mainstream healthcare system and palliative care systems. But largely really to integrate a palliative approach to care in the places where people are living and dying in inner city settings. So in the shelters, in the housing, on the streets. And my own personal entry into this work was as a worker. I worked in harm reduction, in housing justice, activism, and volunteerism. I was a caregiver both to my bio family and also my chosen family. And that's kind of the perspective that I've brought to this work as someone who's a non-medical worker, but who is working in the palliative care world. So why is it important to examine our assumptions about caregiving? So right now we know that about 75 to 90% of care at the end of life happens in community settings, happens among family and friends. Right now, palliative care is in its so-called equity turn, and we're really starting to understand that mainstream hospices, palliative care units haven't in their have not historically, but in their modern movement era, have largely served a white middle class, well-housed, well-supported population of people, largely living with cancer. So there's a lot of attention over the last 10, 15 years to who is hospice and palliative care seeing, and more importantly, who are they not seeing, and how do we better meet the needs of people who are not coming through the doors of hospice and palliative care. We also know that from 2S LGBT Q activism, justice. We know so much, and there's been so much advocacy around the value of the chosen family. Family isn't just who you were born from, but how you make it, and your circle of support around you. And so really, palliative care is attending to not only the patient and the family as the circle of care at the end of life, but also not only biofamily, but also these chosen family networks, friends and neighbors, and their involvement in care. In our work over the last decade, we have seen that there's mainly three groups of people that come around at the end of life to step into caregiving roles. These are workers, as I've been talking about, such as housing and support workers. Number two, biolegal family is still involved for some people. And then number three would be street family, chosen family, friends, and neighbors, or unrelated caregiving networks. And one thing that we've learned in our studies is that the unrelated networks of support are often also facing the same health and social inequities as the people that they're caring for. And I'm going to get a little bit into that in the presentation. And so, but beyond kind of marginalized populations, broadly, we're seeing these large social and demographic trends that mean that, attending to um, not only biofamily, but also neighbors and friends and family. Like, people are living further apart. There's more divorce rates. People are choosing not to have children. There's more family estrangement. There's lots of reasons why we can't assume that family is going to step into the picture to provide that care at the end of life. So I hope through this presentation, also as we talk about homeless populations and other populations experiencing inequity, you might think about how this applies to your own life, because I think we're all people that equity applies to everybody, is what I like to always say. So I'm going to be drawing on multiple studies for this talk today. I'm going to talk generally about some of the big things that we've learned over the last 10 years. I mentioned the early equitable access to care study that really followed people at the end of life and really got to understand from their perspectives what was helpful, what barriers they faced. That was an ethnography, so we really integrate ourselves into people's lives through building trusting relationships and following people longitudinally. We use critical perspectives in our research, so we're really, it's not just about research for research's sake, but about how we learn to create actionable recommendations to improve life and death experiences. Um, so now I'm going to get into the lessons learned. So we find that there's a high degree of estrangement from biologically and legally connected family, which, as I've mentioned, is a tension with assumptions embedded in palliative care that family or biologically or legally connected family are the people that are going to step in to provide care at the end of life. Instead, we find that a constellation of people may step in to provide support, including neighbors, friends, partners, chosen family, and workers in inner city health and social services with different roles and relationships. So there are definitely people that don't have anyone in their life, but I would say largely there are people around. We just haven't, as systems, been very good at seeing those people and understanding how we can engage them and support them in the caregiving network. So neighbors, friends, partners, and chosen family, so this unrelated caregiving network, often engage in care in a community care-like model rather than unidirectionally. So these unrelated caregivers, as I said earlier, are often facing some of the same health and social challenges as the people that they're supporting, and often have similar needs, and most are not identifying as caregivers. So I'm going to give an example of this, but what we've seen is that people don't call themselves caregivers. It's helping each other out. It's often not a caregiver and a care recipient, but rather community care model. And I'm going to give an example now. So Ronald, he lived with multiple comorbidities, and he was labeled failure to thrive by his palliative care team. While David lived with mental health and substance use issues, resulting in ongoing falls and hospitalizations. An outreach worker told us that they were best friends and that they met each other in their subsidized housing facility. Beginning as drinking buddies, their relationship grew from there, and during the study, they supported one another by visiting each other in hospital, providing each other emotional support, and sharing the cost of groceries and supplies. During an observation, David told us, "I look out for him and he looks out for me." So we see a lot of things like people pooling money together, pooling resources, buying groceries, cooking together, and those kinds of things, but they often don't get called caregiving, right? It's just what people do. Unrelated caregivers in contexts of inequity, they often lack access to administrative, technological, and legal processes to document their important relationships. They have literacy issues and system navigation and financial challenges. Consequently, they often remain invisible to the system and are not documented as decision makers or as part of the caregiving network. So I've provided a picture of the Adult Guardianship and Trustee Act, and you can see that even though when we have we might have processes to be able to say, I want this person to be my decision maker, this is my next of kin, that kind of thing. When when people don't have these the access to be able to document these important relationships, oftentimes in the system, we default to family, biolegal family. So when you look at the list that a healthcare provider is looking at to say, oh, nobody's written down here who's going to make a decision for this person. You can see we've got spouse at the top, adult, child, parent, sibling, and where is the friend on that list? Non-existent. In BC, they're at the very bottom of the list, but I haven't been able to see the friend on the list in Alberta yet. So caregiver relationships and roles may challenge our assumptions. These unrelated caregivers may be supplemented with paid services rather than holding primary caregiving roles. The caregiving relationships can be unclear, they can be complex, they can change over time, standing in contrast to a system that expects fixed caregiver roles and family relationships. So oftentimes, we'll have, say, a eldest daughter is the decision maker, she's the main point person, she's the navigator. It's easy for the system to be able to call that number. In the context that we've worked in, often there's multiple people doing multiple things. They might have a worker that takes care of transportation, takes care of some things, but can't make decisions. So then maybe they have a close family friend that is able to do decision making. Maybe that person doesn't have a phone. Maybe that person changes over time. So, there's a lot of fluidity we tend to see in the relationships, and we also start to see a complexity. And we always give this example about, like the person that stops by every day and makes sure the person has food, or make sure they have smokes, or make sure they have what they need to get through the day. And those people aren't always seen as, the caregiver. They might be seen as, oh, they're enabling that person with getting them smokes, but they're that person that comes every day and they check in on them to make sure they're also alive and they have what they need, right? So sometimes the way the system views care is also different than the ways that community view care. And this example kind of illustrates that point. So we talked to this housing worker who there was a lot of people in the building that he managed that were looking out for each other, and they were helping other out with things. But the way that he kind of framed it in the conversation with us is that he says, it's nice they kind of look after each other in the building, but it becomes problematic because these are also people who are very ill themselves. So you kind of get a blind leading the blind situation. This isn't helping them, this is enabling them. So in our studies, we've seen also a lot of judgments around and questioning of whether the care is actually care. And I think there's a lot of tensions in this work. Sometimes there's a vulnerability of people, right? And you see the system coming in to try to protect the vulnerability of people as they age and they decline. Yet they might see some people as being predatory or something like that. So I think there's a lot of tensions, in this idea of what is care, and what is risk and what is safety. And these are huge questions that we could do entire sessions on and have lots more discussion on. So I'm moving on from that. And then for the workers that are surrounding people, they may be in roles that are paid, where they're paid to provide care, but they may also have a kind of closer family-like relationship. So they may fill instrumental support roles. We've, heard countless examples, and I gave the example at the very beginning in that vignette, but we've heard countless examples of workers, going and visiting people at the hospital on the weekend, or going and taking people's laundry home to do it because there's no laundry facilities, but just really going above and beyond their jobs. And so many times this work is unaccounted for. And in some case, like the workers are punished for this work, right? It's you're breaking boundaries, you're going too far. Whereas when you talk to the workers, they say, well, there's nobody else to do this. Like I'm the only one. And so they're composed in this work. There can be some challenging ethical dilemmas between, what is the work, what counts as the work, when does it become more of a family or a friend-like relationship, boundaries, and more complexity there, and can have real consequences for workers too. So an example is a health navigator that we talked to, and she said that she cares for Samson on the side. I asked how she would describe their relationship. I'm basically his next of kin, she said. She went on to say that he has two daughters, a brother, a sister, but that a lot of his family had passed away. She said he has a brother in BC, and there's a lot of controversy there. I asked her why she cares for him on the side. She said, without care, he would be dead. She went on to say that she's known him for so long that she would hate for something to happen to him. So lots of these kinds of examples where, folks that are no longer on the caseload are still being checked in by workers. And then with the biolegal family, or the biologically or legally connected family, despite the fact that, we do see a lot of estrangement, the end of life can provide this time where reunification with family can become important and welcome. So we've heard people talk about this kind of unspoken stepping back that might happen of the friends and the street family when the biolegal family comes into the picture. In other cases, biolegal family can come out of the woodwork, taking over care from friends and family. And this isn't always like an intentional thing, but more that, as I mentioned with the next of kin, like legislation or decision making, that kind of thing, sometimes healthcare and palliative care calls that biolegal family in because they are listed on the medical record. So we need someone to make a decision. All of a sudden, you see this like reuniting of family. The family might not even know about the friends or street family that exist. And so we start to see some tensions arise when we have multiple groups of people coming in at end of life. So this example just kind of shows this example of this unspoken stepping back. It talks about a girlfriend who's been in this person's life for years and years, and then this person has a palliative diagnosis. All of a sudden, the mom and the aunt are on the phone and they want to make that personal connection. And it kind of overshadows the relationship that the girlfriends had for so many years. And all of a sudden, now the girlfriend isn't really around anymore, right? And she's making space for these family relationships to flourish. And this outreach worker talks about this unspoken stepping back. Um, but then we also have examples, as I mentioned, of kind of this takeover of care. And I wanted to give one last example in this section about a man named Jacob. This is a pseudonym, but he was 75 years old and he was caring for a woman in his building. And she knew she was dying. She was dying of advanced lung cancer. And they had a bucket list and they did a will together. And she had wanted to be buried next to her son who overdosed on toxic drugs. And so they had this plan. But the weekend before she died, she ended up going into hospital. And when she was in hospital, because she was so close to death and required decision making, her estranged mom and sister were called in to make decisions. And they didn't know about Jacob. So I talked to him after the fact and talked to him about the experience. And he expressed to me feeling so wounded. And I just want to read a quote from him. He said, "None of it turned out the way she wanted. So it left a hole in me. I felt like I failed. But I can't blame myself. It's something I have to accept. So I hope she's not disappointed up there." I asked him if her ashes went back to the family, and he said she had no idea. I asked if he tried telling them what her wishes were, and he said, "I tried, but they hung up," and repeated, "Already taken care of, took care of it, cremated the same day." So, this is an example of the mom and sister coming in not knowing her wishes to be buried next to her son, making the decision to cremate, the ashes being sent back. And so what we often see is among this unrelated caregiving networks, these workers who can get excluded at end of life, just this prolonged and disenfranchised grief that ripples through communities. And, we have so many deaths in inner city communities. And then when you add on top of that the exclusion from the care at end of life and the post-death experiences, the funerals, the rituals around death, um, just the impact of that for the entire community is so profound. So we're going to move into the next section on what to do about it and just a few things to share here. And then I'm hoping we can have a bit of a discussion. I think we're still doing good for time. Okay. So I mentioned the work that needs to happen in palliative and health and mainstream healthcare settings to really start to see and include and engage not only people experiencing inequities, but their circles of support. This critical reflection on who palliative care is seeing and who they're not seeing. What are we requiring people to do to access service? A safe home, family support, transportation. So really just looking at kind of, what are like, how are our services set up right now? And when I think about the last thing I talked about around grief and loss support, it's like, how do street families and chosen families and workers access things like grief and loss support? Are they seen as that important part of the care network and deserving of these kinds of supports? How can we make services more accessible? And Equip Healthcare has done a lot of work in this area, and they are really working with primary care and other health systems to look at how do we make health systems more equitable. And I've provided a little website, but also we're going to be sending out some resources. So don't worry about jotting all this stuff down after the fact. A noticing of where biolegal family privileging is happening. So, what kind of language are we using when we ask people about who's important to them? Are we saying, do you have relatives or family? Or are we saying things like, who's important to you? Who do you rely on? And keeping it open to not kind of default and move in and assume that everybody has those family support networks. And then also a critical reflection of the policies and legislations that are kind of guiding our work. So an example is the Guardianship and Trustee Act. It's like really thinking about, even if you want to think outside the box and think differently, we have legislation that is governing our approaches to the work. So just, we probably at the end of the day need to make those legislative changes. But right now, noticing how that kind of larger system and structure impacts our work and shapes the work that we do. In our work, we've done a bit of adapted advanced care planning in context of homelessness. So I see this as so valuable because, if we're talking to people earlier about who's important to them and who they consider part of their circle of support, if those people are outside of those biolegal family networks, maybe that flags that, okay, this person needs some legal support um, to be able to document those important relationships. Maybe we can figure out a way to get that into the electronic medical record so that when they show up in hospital, that's the person that gets called as opposed to defaulting to biolegal family. And there's some really cool resources that are coming out that are really accessible advanced care planning, because a lot of the advanced care planning in the past that I've seen is very focused on almost like estate planning and things like that, which isn't so relevant to people, what I've seen, at least in my experience. But and it can be inaccessible. And so there's some cool resources that are coming out that are very lay language, really around, I've provided an example from Advanced Care Plan in Canada, but it talks about thinking about the relationships in your life. Can you name the groups of people or types of relationship? And they're very broad in the way that they talk about it. They say family, friends, healthcare providers, community support. So really getting people to think about these support networks that they have. Who are the people you look forward to seeing, talking, or being around? I really like that framing as opposed to who do you want making decisions or whatever. It's like, who's like important to you? Like who do you want to be around? I think it's just cool ways to think about reframing these questions in a more accessible way. It's so important that we are responding to not only people's health and physical needs, but also, their social determinants of health needs. I'm always thinking about when people are accessing services, what are they foregoing in community to get there? How do they get there? What happened before they came through those doors? And the importance here too is not only, always providing people with social determinants of health, but also making those partnerships with the agencies and organizations that are very knowledgeable in this area. Like, and I'm going to give a few examples here. Like the Community Allied Mobile Palliative Partnership is CAMP. So they're actually a mobile service that exists out of CUPS and within partnership with AHS. And they have a nurse and an outreach and a health navigator. They are connected in with clinical nurse specialist, and they are really going to people where they're at, living in the community, in the shelters, living outside, and they have that flexibility and mobility to be able to provide palliative care wherever people are. And so they're, just a really good resource. And then I was looking at also at the SESNet tool, and a lot of people are starting to use the tool to start to assess for caregiver needs. And I really like that they are asking about, managing relationships in your life and asking about financial or legal or work issues, and really thinking broadly about caregiving needs and support. We need to really, see and value the important and instrumental role of workers. And I've talked a lot about that in the presentation, but just this recognition that while we have like formal palliative care services, we have palliative care happening in the community already by people who will never walk through the doors of palliative care. So we have workers in housing and shelters, we have street outreach workers, Indigenous support workers who have the trusting relationships to be able to follow a person on their journey. And these folks are such an essential bridge into these kinds of models of care. And our team has done a little bit of work to really with workers. I won't say a lot of work with workers to really look at what their experiences of death and dying and care and grief are. We've developed this resource that really looks at building palliative approaches to care in inner city settings, and we're now turning it into curriculum because we're getting a lot of requests from community agencies, hospices, and stuff to say we really need to be able to talk about palliative care in a way that's relevant to people experiencing inequities. So that's what that resource is. And again, all these resources will be sent out to you. Support, more accessible legal support, financial support, and again, just to really support the documentation and legitimacy of these important relationships in people's lives. And then, of course, as I mentioned, just how do we build in support for these networks of people that are providing so much care and facing so much grief. And the grief support often needs to look different in a more of a community or collective grief support as opposed to kind of one-to-one, although there is a place and a role for one-to-one. And finally, getting back to the beginning of my territory acknowledgement, there's this group who run by a researcher, Mary Lou Kelly, and she works with Holly Prince, and they're working out of Lakehead University. And really, we're working with First Nations communities around models of building palliative care capacities in these communities. And I just put this here because I think, we have models that exist out there that really understand that the support network is, not only immediate family, but also extended kin, workers, community workers who may have blurred roles or multiple roles in the community, such as they're paid to provide support, but they're also community members. And, she has this whole model around the caregiving network in First Nations communities. And I just think about like, how do we learn from what has been done already to apply in inner city settings, which is something that, I'm looking into right now. And that's it. And I just wanted to share my contact information. If anybody wanted to email, I'm always happy to take an email. And I have a few social media things and things like that. But again, we'll send this all out. And yeah, happy to have any conversation now. Thank you so much.
Thank you, Ashley. That's really, for me, thought-provoking. I think it's in some ways, it's how we would all like to have our palliative care approached from our community, and how we define that community, right, with it. So to me, it's kind of that cutting edge of pushing our formal services to get alongside with that. Any questions? I have a couple of ideas in my mind, but wanting to open it up to the group here for any questions or comments, just to add to the discussion today.
Yes, don't be shy.
Yeah, put things in the chat box and we can relay that also. Maybe I'll provide a little reflection that I was actually just listening to another speaker, and it was around that advanced care planning and goals of care. And there's a lot of discussion about it's hard to get people to get those done, have those in place. And this work was done in Ontario, and they were really looking at it in terms of culturally. So what are some of the community they were working with was a Sikh community, and so what are some of the requirements that they are needing? And I think that's just along the same lines, like how do we expand those legal documents so that they reflect what we are wanting, what religiously we are wanting, our cultural parts of it too. So again, I think it's there's work happening in different areas that are starting to push at this. Yeah. Anyone else, or Ashley? Yeah, go ahead, Gina.
Hi, yeah, really great discussion. Just a reflection again, as a death educator, working with people of privilege as well. I think that this is a really important conversation because even like I deal a lot with senior women who don't have close family and who are dealing with friends because they've moved away from their family. Um, where I think we just do need to expand in general for people to include friends and the opportunity for us to have trusted individuals outside of the biolegal family. Because I'm seeing that a lot with the work that I do with helping people with advanced care planning and wills and estate and executorship, where it's like, am I allowed to choose a friend? Am I allowed to choose someone? And there's a lot of misunderstanding about how important our friends are in our lives, especially with the way that our society is so mobile and we don't all live near family, and I see that even, just in the general population. So I think it's a really good conversation that's going to help everyone.
Thank you, Gina. Yeah. I was wondering if people had themselves, kind of experiences of either providing support or knowing about situations where, are folks that I think often we think about living on the edge, right? And how to help them, surround them with the support and comfort that they're wanting. Are there any examples that people can think of in their work?
I I just wanted to share. Thank you. This is the
Mhm.
first time I've joined one of these
Mhm.
uh with this group, and it was
Thank
incredible.
you.
I just found it really, really helpful and really informative. And I apologize because someone came to my door partway through, so I'm sorry if I missed this. But
No,
one
no.
of the things that this brought up for me was just those supported decision-making authorizations that I don't think are used a lot or used to their full capacity sometimes in the system.
Mhm.
And I've had a couple people come through the hospital recently who we've worked on those documents together partially because of some of the reasons that you identified, right? It's a friend, it's someone kind of in an informal caregiving role that they actually want to be a part of the discussions. And we talk about the fact that here in hospital, you're with me normally for about 4 weeks. We can have that conversation informally. I can know, but if you end up in a merge, they might not give that person that access. So how do we support both of you to put some of that in place and like put it front and center on your chart so that they can't withhold necessarily the people that you want to identify in your life?
See, Jenny, and welcome. We're glad to have you here. Go ahead,
Yeah,
Ashley.
welcome. I was wondering, Jenny, do you mind sharing a little bit more about that? I haven't heard about it. I'm kind of like learning the Alberta system that I moved back, but I wonder if you could just share a little bit more about how that works.
For sure.
Sounds really
So
amazing.
yeah, I think it's great and I think it's very underutilized. And part of the reason is that I think we focus so much on the documents that say what happens when someone can't make their own decisions. But the supported decision-making authorization is intended for people who are still their own decision makers, but they acknowledge that there's people in their lives that they want to have some degree of access to information or supports them in some of their health-related decision making. And there's different like levels or degrees of access they can sign off on, but both the person and the supporter need to sign the document. Um, and basically it's kind of confirming to healthcare providers, yeah, this is someone that helps me. I am my own decision making. They can't override anything, but they can engage with my healthcare team. They can be here in a different way. And again, it's not appropriate for everyone depending on the level of the relationship. But I've found that when we fill it out, too, there's a way to flag it on the chart, which not everyone's doing, so it can get kind of lost in the chart. But I try to put it in there and flag it so that health providers really see and value the importance of that relationship. Yeah, and if you have questions afterwards too, I'm happy to chat about it more. I'm very interested in it. Initially, they were using it mainly for people with pretty significant hearing loss or English as a second language, where like there was an actual specific communication barrier. But I think that we can look at it more broadly in terms of ways that people interact with the system.
Think it's part of the personal directive legislation package there. Yeah, yeah. We've got a couple of points in the chat there. I'll just go over just from Sharon saying, great point, Gina, and that they're hearing more about that family caregivers. Their caregivers are more broadly defined, friends, neighbors, landlords. Those kind of things. And then from Sue, what a great presentation. We're in a small community and are starting to see more transient individuals, homelessness, poverty issues, etc. Our healthcare system, while fantastic in our community, it is overwhelmed and many people are not able to access the services they need, particularly these disadvantaged groups. So thank you for sharing this information. And yeah, and relevant points from Pam here to her work, really thought provoking. She's just thinking about who to share the info with in their community. Yeah, and so there will be the recording, and please send it out far and wide to people. It is interesting to think about some of those smaller communities and what kind of some of the impacts there are that might be different within a larger center. But we'll go to Sharon first because she's got her hand up.
Yeah, yeah. So my sister up in Lac-La-Biche, they actually did a thing on who gets grandma's yellow pie plate. So they talked about advanced care planning as part of the program for adult learning and reading and making decisions and that sort of thing. And many people had green sleeves, but getting a family doctor to sign them is really difficult, especially in rural areas. And they're not valid without a physician or nurse practitioner signing them.
Interesting. I wonder if some of those resources that you shared before, Ashley, will help at least gather that information and if it's not one that needs to be signed, it at least has the information there for people to know. Yeah. Great.
I was just gonna comment to Sue. Thank you for your comment about smaller communities. And I think one thing too that I hope with this work is that like I think health and palliative systems feel very overwhelmed by the amount of social issues that they're seeing come through their door, and they haven't been designed to meet those needs. And so we are seeing like lots of innovative approaches that incorporate the social determinants of health. But one thing I would also hope is that, from this work is really to like support seeing what are the organizations and community that are able that we can partner with in health and palliative care, because a lot of the people in the study, at least that I did recently, were connected in with, say, an inner city health organization. They had housing workers. They might have a case manager that's following them and able to transport them to appointments. So I think people often have these folks that are able to take on certain roles, maybe not everything, but they can take something on, and we need to build those partnerships and systems of communication, because then we also have problems of like, oh, the health system can't talk to the community organization because of so we have like lots of barriers around communication and information sharing, and so that becomes a barrier to groups working together. But I would hope also, yeah, just to really see and value where the care is already happening. And then like I think about food banks. Like food banks are seeing people in small communities every like once a month, like what is their role in a palliative approach to care? I always think like there's the possibilities are endless, and especially in smaller communities that tend to just get things done because they don't have necessarily all the programs and services as the bigger places. So yeah.
Nice. Yeah, that's really, yeah, bringing those partners together, right? And building capacity and understanding. An awful lot of palliative care is very similar to every other type of care, but it may happen more frequently. And of course, pain and comfort becomes priorities, right? So I think it's kind of demystifying some of the what is that care? So and having the folks that have been walking alongside that person there, for the last while is really important as part of that. Mhm. So I'm just getting in there a little discussion about green sleeves in the comments about that they're hard to get. Do you order them from Alberta Health Services? So Merle is asking, so what happens if neither person can read or write and they just have a verbal understanding with each other? Have you seen ways of addressing that, Ashley, for the folks that have kind of lower literacy, I guess?
So I guess what I've seen in the work, because I've followed quite a few people who have been followed by these mobile palliative care teams, is that
Mhm.
those teams, because they have a lot of experience working among lower literacy levels and diverse needs, is that they can support the valuing of the caregiver or the friend in the decision making informally. So, if that person, with the person's permission, bringing that person into the conversations, or things like that, like supporting that, the collective care that's happening in the moment. But I've seen that what happens when the person dies and then
Mhm.
the teams leave their care or something like that,
Yeah.
then the system kicks in and that person falls off the map and isn't seen anymore. So I really see, while people are alive, so much can be done with them and in collaboration in their care, but so much of that is happening informally. And then when the formal system kicks in, then it's like, oh, we have no record of you. So
Right.
and you don't have a phone and you can't communicate. So,
Yeah. It's
like
really around, whose need are we meeting there? We're meeting a
yeah,
system need.
yeah,
They feel they have to have that in place.
yeah,
Because so much of what, friends and family do for people at the end of life they don't need in-depth knowledge of a health situation, or the diagnosis or any of those kind of things. They're there to be able to say, they're in more pain. That's all they need,
right.
that's the kind of role that they're playing, right? So I think that information becomes a barrier because of the work it takes for the communication, right?
Yeah, absolutely.
Yeah. Just seeing from Lisa here, I think there is great opportunity for this work within the new integrated health neighborhoods that are being planned with Alberta Health and primary care networks. Yeah, absolutely, Lisa. I think it could be a real. I keep looking for integration points across our four organizations that have been set up, and I think that this could be one of them for sure. And then just just some talk about some difficulty with those green sleeves in the chat there. So thanks for sharing that. And yeah, maybe Pam, you can help there, move that along for the other person they're looking for. I think it was Gina, right? Yes, yeah. Looking with that. Great. Well, thanks so much, Ashley. I think it's super to kind of open up these discussions and be thinking about it. You know, it's that care across our lifespan, right? That is starting from day one all the way to the end of our lives, and how can we ensure that the communities that we are part of are recognized and supported all the way along. And I love that we're recognizing more around that after death care for everybody that is part of that community, and needing to be I think more mindful about that, and trying to recognize and pull people into the supports that are there, that other people are accessing with it. So thank you once again. I'm just going to share my screen just to cover a couple of resources that we'd like to share with everyone. There we go. Yeah, so the top one here is in September. Look at that. As we're heading into the summer, we're already looking for September. So Caregivers at the Center Conference being held at the Northwest College's Family Caregiver Wellness Initiative. And so it's free to attend there. And then also I just want to share with people that the World Health Organization, it will be launching a framework to implement a life course approach in practice. So looking across that life course about how to reorient health systems to produce health for all there. And then I think.
Gee, wasn't it at the Alberta Association on Gerontology event that somebody pointed out that the life course ends at doesn't include palliative care?
Oh, yes, yeah. Look at all the good conversations that are being pushed out here. Yeah.
Eric Wasalenko, yes.
Yeah, that's right. So thanks everyone for joining today, and I hope everyone has a great summer. We're not having meetings over July and August, but we will see you back here in September. Great.